This CT scan shows left-sided cholesteatoma filling the entire middle ear cleft with a lateral semicircular canal fistula, as well as some erosion or thinning of the tegmen tympani. This patient is presented with history of severe vertigo and some imbalance for the past 7 to 8 days, associated with severe progressive hearing loss in the past 7-8 days, though the history of discharge and hearing loss dates back. You can see how the middle ear and the external auditory canal shows a polyp, as well as the entire middle ear cleft shows a soft tissue lesion, as well as the presence of a lateral semicircular canal fistula and tegmen erosion in the most anterior superior part. The opposite side also has a cavity from a surgery done many years back, which is healing well. One also can see the emissary vein on the left side. Now, our goal here is to create a subtotal petrosectomy with cul-de-sac closure, because in the elderly patients at 72, in the presence of a severe to profound hearing loss, we want to be definitive with their surgery. We do not want frequent visits to the office for suction toilet that often initiates vertigo in these patients, much more so when the canals have been already destroyed and they're exposed to the environment and the hot and cold temperatures. So it is from our side, it is far easier to rehabilitate them, even if one has to do a partial labyrinthectomy for clearance of disease, and we would not need to call these patients for frequent follow-ups. So our goal is to have a definitive surgery, do a partial labyrinthectomy if at all it is required, and close this ear cul-de-sac with fat obliteration for good. Now what we are seeing here is we are creating the cul-de-sac, trying to separate the external canal skin from the cartilage and everting it outside the canal generously to repair it using absorbable sutures. We do not recommend using non-absorbable sutures or removal of these sutures. One can use Vicryl or PDS. We are using PDS sutures here for their sheer resilience and strength and their long-term durability. The amount of eversion that you see here often only looks a lot in the immediate post-operative period. A few months later, it sinks inside, with leaving no unnecessarily protrusion as compared to some unfounded fears by patients. The next layer is the cartilage layer. We use the suture the tragal and the conchal cartilages to each other to reinforce the cul-de-sac. Is also a very, very important layer. We do not recommend that only a single layer be used. So the cartilage is very important. The sutures must be thick and taken through a lot of tissue, and one should be cautious as to not create a cut through in the cartilage, because once that happens, that portion of suture becomes very poor and weak. Now once you see that the second layer has been made, now we start creating a large inferiorly based musculoperiosteal flap in a standard way as one creates in a mastoidectomy. And then once that flap has been created, adequate amount of mastoid cortex has been exposed, we need to excise the medial portion of the canal skin. And for that, we use a monopolar cautery right to the bone to be very, very sure that we are not leaving behind any fragment of skin in this part. The entire circumference of the external bony canal has to be clean, bare to the bone, so one can be sure that no portion of canal skin is left behind, because then that would amount to creating an iatrogenic cholesteatoma in these patients, because there is no egress. You see here how the lateral bulky part of skin is initially excised till we start seeing the medial part of skin, which shall be duly elevated using standard elevators. Before that can be excised as well. Here the goal is very radical. There is nothing important here. So you want to use the monopolar cautery tips right to the bone to be able to excise this lateral thick skin, even with some fragment of cartilage left. As you see, we have done that. Now we just drill the slight part of the external canal, the lateral part, to be able to see the medial skin carefully, since this patient had an oral polyp courtesy cholesteatoma, and a generous canal drilling is required to be able to identify and conclusively elevate the medial canal skin right to the level of the tympanic annulus to be removed, which is normally removed along with the remnants of the ossicles, if at all, though there were no ossicles here in the CT scan, but in case they are, they have to be removed with the tympanic annulus as well, which is basically the malleus and the incus. As this process is started, one can see that we are gradually, progressively start drilling. There's no concept of doing a cortical mastoidectomy here. This is a radical procedure. So at the outset itself, we start creating the cavity. We start drilling the canal inside out to expose the attic as early as possible, and bringing down the antrum, following the attic posteriorly, and creating a cavity as quickly as possible, because this is a radical procedure. And since this is radical, we do not have to be dogmatic about the amount of bone drill. We can drill inferiorly, superiorly, anywhere as much as the disease demands, because eventually all this will be obliterated using abdominal fat. You see here, the CT had shown us that there was some dehiscence of dura superiorly towards the attic region. We'll keep that in mind while we drill. But as of now, as you see, we are drilling the superior attic. There is a small cotton ball for protection of the middle layer tissues. We don't want to damage them or tear them with the cutting burr, though in the end they'll still be removed. But in the interest of a neat and clean procedure, it's important that normal routines and protocols be followed. As you see here, we are doing some medial drilling. This has two reasons. We have to, of course, expose the attic completely. A generous, large canal wall down cavity has to be created. The anterior epitympanum has to be opened widely. The hypotympanum, if required, also has to be open. Here we are conclusively drilling the entire canal wall, lateral to medial, to be able to conclusively identify and expose the bony annulus, so that we can clear the entire tympanic annulus and any buried skin underneath it, because anteriorly we want no skin to be left behind. Normally we do not do this step in routine mastoids anteriorly, because anteriorly we let the tympanomeatal flap be there, which rests on our graft. But here, since everything will be removed, it's imperative that the anterior bony wall be drilled, sometimes right to the temporomandibular joint, for correct identification of the bony and the fibrous tympanic annulus anteriorly, because that has to be removed as part of specimen. Now you see how post the aticotomy we are bringing our drill back to open the antrum, and gradually, one by one, the entire mastoid air cell system, crafting a canal wall cavity as one would do in inside out surgery. The same techniques prevail. And even here, we would go for a saucerized cavity. We would go for a generous lowering of the facial ridge. We would go for everything that we do in a routine canal down mastoid, which is opening of the anterior epitympanic space, and whatever that be. However, if the inferiorly, we have a lot of liberty to go, whether it's the middle or the mastoid, because we're not keeping this cavity open to the environment. So inferiorly, we can trace this disease as much as it goes right till the mastoid tip, if that is required. Now you see, we are trying to be quick here. We're using a sharp cutting burr to keep drilling over this area. Now, sense of a cavity can be appreciated here. The fact that we have opened the mastoid cavity, the aticoenterostomy has been done, and now we are drilling off the posterior superior wall, the posterior wall, the boundary, which is basically the bone lateral and posterior to the sigmoid sinus, is being drilled off to expose the entire antrum and the mastoid cells to clear them of all disease. And now you can start seeing granulations and epithelium in the medial part of the mastoid cavity, superiorly towards the region of the antrum. Now you see, again, we have at this point of this stage, we have continuing with the cutting burr, because we want these steps to be quick. These are rather crude, and we do not want to be spending a lot of time with diamond burrs here. So as you see, we are going inferiorly. We are also keeping in mind our superior boundary to make sure that we do not leave any cells behind, because this cavity would be obliterated. Leaving behind cells can always lead to mucoceles and unnecessary infections inside the cavity. I'll remind you that the subtotal petrosectomy basically ensures a canal-wall-down mastoidectomy, obliteration of the stitch and tube orifice using periosteum or muscle or cartilage, removal of all entire middle ear mucosa, all squamous epithelium inside the middle ear cleft, and then obliterating this mastoid bowl using abdominal or thigh graft coupled with the cul-de-sac closure of the external auditory skin. Now you see here, once the posterior part has been drilled, now we are drilling off the inferior part of the middle external auditory canal, that is the tympanic bone anterior to the facial ridge, to be able to be 100% sure that entire bony annulus inferiorly is being exposed. We don't want to leave any skin or fibrous annulus there. For this part, we resort to a diamond burr. It helps us in avoiding any untoward contact with any important structure, as well as helps in hemostasis. See how important this step is. And as we have drilled the lateral in the mid-level canal bone, we are now able to see the bony annulus entirely. This is so important because most canals have overhang that inhibit visualization anteriorly and inferiorly. So you see that we have drilled inferiorly, we have drilled anteriorly considerably, and now after that we resort to lowering our facial ridge on all directions, both anteriorly, thinning it as well as lowering it to the level of the actual facial nerve, while at the same time continue to expand and drill the anterior canal bone or the anterior tympanic bone. This also makes sure that any skin remnants that have gone beyond the tympanic annulus anteriorly are also drilled off and removed. So very wide exposure is very, very important. This step must not be taken lightly at all. This is a fundamental part of any subtotal pedosectomy and cul-de-sac closure, because 100% visualization and clearance of any squamous epithelium and in fact most of the middle ear mucosa is imperative to success of this surgery. Now you see, once this has been done, you can see the tegmen exposed here. The dura is exposed, which is now being cauterized, not just for even hemostasis, but also to shrink it so that we are able to see medial to the dura, as well as to 100% confirm that any residual squamous epithelium that is left from the dura should be coagulated generously with a bipolar cautery, so that does not lead to any cholesteatoma formation. One has to be cautious around dura in elderly patients because dura can be very fragile in these patients. Any aggressive movement or suction has the potential to damage it. Now see, we are clearing off the mucosa and the entire fibrous annulus anteriorly, gradually teasing it outwards from the medial part. This is again very important to not leave behind any mucosa or squamous epithelium. Once that has been done, we resort to drilling medially towards this sinodural angle, as well as enlarging the space where we have the granulations and the destruction of the lateral semicircular canal, which needs to be definitively cleared. Here we are resorting to a diamond burr to avoid any vascular injury and to avoid the injury to the exposed dura. So as you see here, now once the granulations are being cleared, we are also drilling the medial part of the mastoid, which is some of the residual mastoid cells, air cells, as well as the labyrinth, gradually to be able to 100% completely remove all the epithelium and the granulations from this destroyed labyrinth. Is very important. We do not intend to leave any disease behind in these patients. Since we are doing a cul-de-sac closure, we would drill and even not refrain from doing a partial labyrinthectomy if required. Now you see how carefully the anterior tympanic annulus and any associated epithelium with it is removed in toto using angled picks or standard plaster knives or circular knives to be 100% sure that anteriorly and inferiorly, where the vision is less, after drilling, one can completely and block remove the annulus to be sure that no squamous epithelium remnants are being left behind. Now see here, the squamous epithelium is removed. All that remains is the middle ear mucosa, which will be tackled shortly as well. And now this entire annulus is now being removed. The residual middle ear mucosa can be stripped or generously coagulated. Here, as you see, we are removing the squamous epithelium from the exposed tegmen dura. gradually and carefully using a broad elevator. Sharp elevators are risky because they can puncture and pass through the dura. So we always prefer little blunter side and broad elevators. Now you see how the disease adherent granulations and the epithelium is adherent to the dura in the most superior and the medial part of the most medial part and the anterior part of the tegmen. Now from this, the granulation and the epithelium has to be carefully peeled off. The dura can be very fragile in elderly patients, so one should be cautious in peeling this disease off. If it is too firmly stuck, then one can use sharp instruments and sharp scissors for dissection of the epithelium and the granulations from the dura rather than using blunt elevation and force, which can lead to tearing of the dura. Once that has been done, we see that the diamond burr is used to once again remove any amount of bone left over the tegmen, as well as the medial wall of the mastoid, that is the labyrinth, and it's being drilled to be conclusively removing the entire epithelium and granulation tissue, which is infected and is still covering the lateral semicircular canal fistula area. Like you've already said, hearing is not our concern. Some amount of vertigo post the handling of the lateral canal, whether it is soft tissue or drilling, is always there. Our patients are always briefed for this eventuality, and normally we always recommend that they be mobilized from day 2 onwards, so that the central compensation can kick in. We do not recommend any vestibular suppressants beyond first day for these patients. Now we are seeing that we are lowering the facial ridge post some drilling of the lateral canal region and the most medial and the anterior part of the dural plate. This is very important to identify the facial nerve correctly. If the facial nerve is dehiscent, or if it is intact, or it is involved with the cholesteatoma and granulation. Now, as you see, we start seeing the shadow of the facial nerve, the tympanic segment that is curving at the second genome to become the mastoid segment. You can see how the lateral canal is perforated already, is eroded because of formation of fistula posterior to the facial nerve. Now, since this is a radical procedure here, we can definitely use a cotton ball to firmly mop any granulation tissue or diseased epithelium from the region of the labyrinth or the medial wall of the mastoid. Anteriorly, once again, one has to be very sure of removing any epithelium or squamous epithelium that remains towards the protympanum as well. One can see the tympanic segment of facial nerve ending at the at the processus cochleariformis into the geniculate ganglion superiorly, and the facial nerve can be seen to be disease free. Now the middle ear has to be cleared, like you've seen that we are removing any amount of tissue granulations or disease in the posterior mesotympanic recesses using whirlybird dissectors, as well as followed by coagulation of the residual middle ear mucosa for bare bone to be there. It's important to know that fat adheres to bare bone very well and not to mucosalized regions. So it's important to remove as much as mucosa as possible for adherence of this fat to this bare bone, the mastoid. Once the fibrous annulus was removed earlier and the middle ear mucosa is removed, we still recommend that the inferior tympanic bone to be drilled thoroughly to even remove the bony annulus, to be very sure that there is no squamous epithelium or gross mucosa left there. So as you see here, the tympanic bone has been drilled, and now whatever little mucosa is left behind there is being now coagulated using microscopic bipolars. Now the medial part of the mastoid is now being drilled to completely remove these granulations, including the lateral semicircular canal and the position of the posterior semicircular canal. These are again drilled exhaustively using a diamond burr to completely remove all granulations and disease-infected mucosa from this, because since we are using a free fat here in the cavity, it's important to be attempting near complete disease removal so that the fat doesn't get infected. Fat being infected is a known complication of this kind of procedures, and once that happens, that infected fat has to be removed, as antibiotics have virtually no penetration into the bowel post surgery. So whatever it is, sincere attempt has to be made to remove disease conclusively from the middle ear cleft by surgical means, which is active irrigation, thorough amount of drilling, removal of mastoid air cells, removal of diseased mucosa, removal of granulations wherever they are, and removal of any squamous epithelium in the middle ear cleft, so that the chances of any return to the operation theater in these patients are to be kept minimum. During this step of surgery, once we are somewhat close to the completion and we are drilling off the labyrinthine bone to make it smooth and remove all granulations and disease, one of the assistants will begin harvesting fat from the abdomen or the thigh based on prior discussions to harvest some fat. That fat is normally kept either in gentamicin or rifampicin solutions. Gentamicin is fine if there is already hearing loss or labyrinthine destruction. If not, and if the patient has a mixed hearing loss or a severe conductive hearing loss, in that situation one can use rifampicin, IV rifampicin, for the fat to be soaked in it for 10 to 15 minutes. But ideally the fat should be removed as close possible to the final closure, so that the fat is exposed to the environment for the least amount of time and avoids infection. The drilling is done over the superior part as well, towards the location of the superior canal. As you can see, where the superior semicircular canal lies, this region is being drilled. So this is like a partial labyrinthectomy, where some amount of lateral canal and superior canal are drilled to completely clear disease. One can see how disease has been totally cleared from the mastoid and the middle ear cleft. The facial nerve is nicely visible. The middle ear has been cleaned. The mucosa has been cauterized wherever it is left. Most of it has been removed. The facial nerve is intact. And anteriorly some amount of leftover mucosa granulations are now being removed as well by sharp dissection. The tegment dura has been coagulated nicely, and for most part the bulk of the procedure has been done. The last part of the mucosa anterior to the facial nerve is now being removed. One need not be scared here. The facial nerve is not here at this position. The facial nerve turns much more posterior to it into the labyrinthine segment. One can casually see that at the level of geniculate ganglion. Anteriorly, this is just mucosa which has to be cleared from the protympanum and the anterior epitympanic recess, so that does not lead to any future mucocele formation. Now you see how we are stripping out the mucosa from the protympanum and the eustachian tube orifice as well. And again, we are drilling it anteriorly, anterior-superiorly, to be able to again conclusively provide bare bone for our graft to adhere to the eustachian tube orifice. We can use periosteum or cartilage or both, and we may or may not use bone wax over it to completely set that in the eustachian tube region. This is done to basically isolate the cavity from the nasopharynx in the nose. So you can see for the most part our bony work is now being completed. We're using a long skull base suction to clear the mastoid bowl, and now we're using broken down cartilage which has been cut into small parts with some perichondrium to be pushed inside the eustachian tube orifice snugly. And once we feel that we have snugly placed it inside the eustachian tube orifice, we use bone wax over this fragmented cartilage to secure this tissue onto the anterior anterior tympanum or the eustachian tube orifice, so that secludes the middle ear from the nasal cavity and nasopharynx.